Yeah, that's a great discussion. Okay, our next speaker will be Dr. Dan Zhang. Dr. Dan Zhang completed her medical degree and PhD in China, and her postdoc training at McMaster University, where her research focused on kidney fibrosis. She is currently a PGY3 resident in diagnostic clinical pathology at University of Saskatchewan. Her primary academic and clinical interest in medical renal pathology with particular focus on transplantation and immunology-related kidney diseases. Let's welcome Dr. Zhang.
Thank you for introduction. As Doctor mentioned, I'm Dan Zhang, and I'm the pathology resident from University of Saskatchewan, Canada. And today, I really appreciate this opportunity to present our work on computational pathology of kidney transplant biopsies. Oh, sorry.
That's the laser, and this is forward.
Oh, this is forward, sorry. I have no conflicts of interest, and also this work received ASHE Best Written Lay Abstract and the Travel Awards. I really appreciate it for. Thank you. So let me start with a little bit of background because I suspect most of you in this room know the immunology better than me as a pathology resident, but I think it's still worth to set up the stage for my presentation. So kidney graft rejection is broadly classified as antibody-mediated rejection, also called AMR, driven by donor-specific antibodies binding to mismatched HLA, and T-cell-mediated rejection driven by donor-reactive T-cell infiltrating and damaging the graft. So traditionally, we have relied on antigen-level HLA matching, but antigen-level matching does not fully capture the alloimmune risk. So that's where the molecular epitope scores come in. They quantify the mismatch at the amino acid or peptide level, providing more precise information. There are two tools we have a particular interest in our study. The first one is PIRCHE, derived from the snowflakes, a snowball, as I mentioned in the slides. Those two algorithms quantify the exposed amino acids likely to be recognized as B-cell epitopes. And PIRCHE T2 estimates the number of donor-derived HLA peptides that can be indirectly presented by the recipient's HLA class II molecules to CD4 positive T cells. So our hypothesis in the study is that high PIRCHE would predispose to AMR, while high PIRCHE T2 would predispose to TCMR. So let's have a look at our study design. This study was a retrospective single-center cohort study at our institution. There were 15 kidney transplant patients between 1981 to 2021 with follow-up through January 2024. 4 cause biopsies were included, and also those biopsies were classified according to Banff 1997 to 2022 criteria. PIRCHE and PIRCHE T2 scores were calculated based on HLA resolution, high-resolution HLA genotyping, and the commercial PIRCHE platform. De novo DSA and the statistical analysis, as I mentioned in this slide, were performed in our study. This flow chart, I want to show how we arrived at our analytical cohort. So we started with initially 615 patients, and 21 of them were excluded due to missing data, and 594 patients as the remaining patients, there were 395 patients underwent a 4-cause biopsy, and 49 patients were then further excluded because those patients, as per the most recent Banff clarification 2022, they are reclassified as probable AMR, so we exclude them just in case avoid the mix-up, and also for the remaining 54 patients, including the study, we have 40 patients with antibody-mediated rejection alone, and 65 patients with T-cell-mediated rejection, and 39 patients with both of them. So in terms of the baseline characteristics, we have lower risk, lower median age, in the rejection groups, and also we found ethnicity, pregnancy history, blood transfusion history, and the retransplantation were all enriched in the in the rejection group. And also we found there are 55 patients with positive de novo DSA in the rejection group too. So let's have a look at the result. The first result we found that is PIRCHE-B and PIRCHE-T2 scores were higher in rejection group. So both PIRCHE-B and the PIRCHE-T2 scores were significantly higher in the rejection group, as I showed here. And this result shows that the overall epitope mismatch burden is linked to rejection. And also what is important here is that different loci matter for different pathways. So PIRCHE-B at DRDQ, as I highlight here, aligns with humoral responses mediated by B cells, while PIRCHE-T2 at HLA class 1 loci aligns with the T cell biology. So this result supports the idea that these algorithms are not just the statistical tools, but actually reflect the underlying immunology. So secondly, we found antibody-mediated rejection is strongly associated with higher PIRCHE-B scores. So antibody-mediated rejection, as I showed here, especially at DRDQ and DQ loci, and this result reinforces that the B cell epitope load directly translates into higher risk of antibody-driven injury. Next, we found that T cell-mediated rejection was associated with higher PIRCHE-T2 and PIRCHE-B scores too. In both of the graphs, we can see, so especially at the HLA class 1 loci, we have in the PIRCHE-T2, we have higher scores in the rejection group. And also both of the past two slides findings, we found that those two slides support the concept of two distinct immunologic pathways, B cell epitopes driving AMR and indirectly recognizable peptides driving TCMR. Secondly, after this, we have the look at the Banff lesion scores. So Banff classification criteria is the diagnostic criteria for kidney graft rejection. In here, we found both PIRCHE-B correlated with microvascular inflammation, which means glomerulitis and peritubular capillaritis. So they are both have a overlapping at DRDQ and DQ loci. Those two histology features are the hallmark features of antibody-mediated rejection. And also, we also found that both PIRCHE-B and T2 are correlated with cubulitis and arteritis. So consistent, also those are the markers of T cell-mediated rejection. So those two results are actually a really powerful validation step because the PIRCHE scores did not just predict rejection categories, they also can line up with the specific Banff lesion scores or Banff lesion patterns we would expect in the study. Then we use the ROC analysis to identify threshold values that could separate patients with or without rejection. So the strongest predictors we have, as I mentioned here, are PIRCHE-B, PIRCHE-B DRDQ, and the PIRCHE-T2 total, PIRCHE-T2 class 1. Also, I list the specific scores here. So we are using those thresholds and also applied them to the analysis. We found that they clearly stratified patients into higher and lower rejection risk, as I showed here. So higher PIRCHE-B predict earlier onset of antibody-mediated rejection, and the higher PIRCHE-B T2 predict earlier onset of TCMR, T cell-mediated rejection. This result confirmed that the thresholds actually reflect the timing of clinical rejection events. In summary, I just want to make it clear, for antibody-mediated rejection, PIRCHE T2 total scores and higher PIRCHE T2 total scores and DRDQ scores can predictive for high risk of AMR. And for T-cell-mediated rejection, PIRCHE T2 total score greater than 65 and class 1 greater than 31 can be can indicate for TCMR development. So then we use those scores, combine those scores into a composite risk model. Patients were stratified into 3 groups. On the left line, you can see we have PIRCHE B total and the PIRCHE T2 total as a group to stratify the patients, and the right side we have PIRCHE DRDQ and PIRCHE T2 class 1. So for both of the low risk group, we have all scores below threshold, and the intermediate risk group, we have 1 score above the threshold, the other one below the threshold. And the high risk group, we have PIRCHE B, we have both scores above the threshold. So as a result, this composite results show that we have a stepwise separation of a rejection-free survival, with the high-risk group doing the worst and the low-risk group doing the best. So this result suggests that B-cell and T-cell mismatch scores are complementary, and if we combine them together, it can give us a more accurate risk stratification than either score alone. So next step is how could this could be used in real practice. So our suggestion is for pre-transplant risk screen, high PIRCHE B, if the patient donor pair has a high PIRCHE B, that flags the risk of antibody-mediated rejection. So we may prioritize antibody monitoring, desensitization, and stricter donor selection. And if the patient donor pair has a higher PIRCHE T2, which flags the risk of TCMR, so we can ensure the stronger T-cell control, optimize the CN inhibitor dosing, and also stress adherence. And for the post-transplant patient, we can use the composite risk model to guide the intensity of monitoring. And so high-risk patient might need a closer follow-up and earlier biopsies. But importantly, we need to know those scores are not standalone tests. They must be integrated with HLA matching, DNA monitoring, and Banff histology. So we do have limitations in our study. As I mentioned before, this study is a retrospective, single center, and only include the for-cause biopsies. And also, so for us, the next step would be multi-center external validation, prospective scoring, and integration with more immunologic features like complement binding DSAs and also non-HLA antibodies. So to summarize, PIRCHE B is linked to antibody-mediated rejection, and PIRCHE T2 is linked to T-cell-mediated rejection. Simple threshold and composite models stratify rejection timing in our study, and those tools, when combined with the DSA and the Banff histology, moving us slower to the precision transplant medicine. And also, I would like to take this opportunity to thank my supervisor, Dr. Mustafa, for supervision, and also my co-authors and all the collaborators and lab colleagues who made this work possible. Thank you. I would like to take any questions.
Yes, thank you. Any questions? Oh, Raj.
Sorry.
I'll take. You'll be right there, Raj. Hold on.
Thank you.
So I can appreciate the study, the reasoning for this study. Mm-hmm. In your cohort, it seemed to me that you had 40% DSA negative, mm-hmm. Microvascular inflammation positive rejections.
Yeah, this is a really good question. When we do the study, we do found there's a 40% negative DSA positive in the rejection group. But the problem is our test is just for the HLA antibodies. So as per the recent Banff score or Banff classification, we need to perform the thorough like including, as I mentioned, the non-HLA and also the other subclasses of IgG to make sure if the patient is just going through the other antibody, or mediated by the other antibodies. So I'm not sure if I explained this question well.
Right. So I don't know if that argument holds because these are calculations that are predicting antibody generation to these particular molecules, but you're not detecting those.
Mm-hmm.
So what would make more sense to tighten up your statistics is to simply remove that cohort from the PIRCHE calculations.
Honestly, because we based on the result of pathology report, for the diagnosis of kidney rejection is not only the novel DSA in the serum, it's also including the C4D antibody, like IgC, when the pathologist...
I understand
Yeah.
how the biopsies are scored, but what I'm saying is I think you're diluting your results.
Yeah.
Because you're adding a cohort that's irrelevant to PIRCHE scoring, right? You don't have antibodies to that.
Yeah.
Right,
Yeah.
and your statistics are borderline as it is. So to tighten that up, I would simply remove all those cases.
Okay, yeah, that would be a great direction. We can do it in the future. We just here we just want to present the overall picture of our population. But yeah, it is a really good direction. Thank you so much for your recommendation.
So your cohort includes transplant done for the 40 years, starting from 1981. So those times we don't have any anti-thymoglobulin, no single antigen testing in 1980s, 1990s, no DSA testing, no ABMR calculations, or no C40 dining, no DNA typing. How did you get this?
So actually, we have some saved serum. I'm not sure if that's right, but we have some saved serum in our lab. So we all the serum, all the resource available patients, we tested those ones using high resolution HLA genotyping, and to make sure that. Yeah, unfortunately, as you said, we don't have that C4D or the other techniques to make sure if there's antibody positive in those patients. But I include all the data I have into the study. So that's.
Thank you.
Thank you so much.